So this next lecture, just listen, just write down little stories, whatever, because most of the stuff you've already gone through already, but from a neuro perspective, there's a couple other things that we do as well, or why we do them. So just kind of listen. So I'll talk about taking a neural history, and then your focused neurological exam, and then talk about different things we do for other parts. So, is the patient even capable of giving a good history? If they're not, don't do anything else with the patient because you can't trust what they're saying. Then you have to talk to the family members, especially if they come in confused, obtunded, delirious. You're not going to get anything out of that patient. Don't even bother. Talk to family members. Are they unreliable? Are they unwilling? Can they not? What's their affect like? Accurate description of the problem. Okay, talk to relatives who saw this patient fall. Whatever, ask them what happened to the patient. What was the mechanism of injury? What was going on? And then answer this neurological question. Is the problem with the brain, spinal cord, nerve root, peripheral nerve, or the muscle? I can even add in there neuromuscular junction. Okay, you got to figure out where is this problem coming from? Is it a brain issue that's causing them to have these neurological issues? They had a stroke. Is it a herniated disc that's pinching their spinal cord, pinching the peripheral nerves, causing this radicular pain and so forth? So as you go through your exam, you ask these questions and you figure it out. Onset and timing is very important. Sudden onset with slow improvement suggests a vascular event. Stroke, TIA, something's going on with the vasculars. If it's a gradual onset with a gradual progression, so it's very insidious, just comes along, think tumors or dementia. Those are very slowly progressing diseases. Gradual onset, it takes a long time to really start having an effect on these patients. Do they have exacerbations and remissions? Does it come and go? They get flare-ups. Multiple sclerosis has flare-ups. What is multiple sclerosis? It's a demyelinating disease. Okay, so anything demyelinating, Guillain-Barré, is another form of a demyelinating disease. They have exacerbations and remissions. They do well and they have a flare-up. Delirium can also have exacerbations and remissions as well. And always ask about trauma, okay, especially in the head, causes problems. Your provocative and palliative factors. Is it worse with stress? What happened before you started getting these problems? When we get to headaches and facial pain, we're talking about doing like a headache diary. When you have a headache, what happened before? What were you eating before you had this headache come on, especially from like migraines? How frequently are you taking pain relievers? Okay, if your pain is not controlled and you're popping pills every 6 hours, something is going on. What's going on? Does light or noise make your headache worse? It's called photophobia or phonophobia. Anyone have migraines? Okay, what symptoms do you get? So pain with left-sided. We're going to learn about the pound mnemonic for migraines, and the U is unilateral. So she only has it on the left side. Does it come on with reading? And obviously, what makes it better or worse? So some questions to ask your patients. What was going on? Why is it getting worse? The quality of the symptoms. Okay, is it lancinating, knife-like? Someone's like stabbing you with a needle, causing pain. Ice pick headache, a throbbing headache. Okay, throbbing headache, it feels like there's a band around your head and it gets worse and it gets better, worse and better, throbbing and so forth. Ask your patients to describe what the quality is like. Where? Okay, is the headache only on one half of the head? Paralysis on one half of the body. Numbness, stocking glove distribution. Where are they having their numbness and tingling? Where are they having their weaknesses already? I hope none of you are here already. Severity of the symptoms. This is subjective measurement. Some people have very low thresholds of pain. Some people have very high pain thresholds. So ask them to rate it. If you use the same scale, 1 through 10, every time they come in, hopefully you'll get, yes, I'm a 5 today, I'm a 4 tomorrow, whatever. Don't know. Medications and allergies, ask them again how much pain medicine they're taking, any psych meds, any herbals. People think that herbals and supplements are not medications. They are medications. They're just not regulated, and it makes it even worse. But ask them what they're taking. Any street drugs, and obviously your allergies, ask about allergies. Past medical history, past surgical history, ask them about headaches, seizures. Obviously, here's your trauma. Have you ever had any infection around the brain? Psych issues, toxin exposures. How would you find out about toxin exposure? Occupation. What do you do for work? Stuff like that. And any developmental delay. You guys will start learning in peds developmental milestones. By what age do they start doing certain activities and certain things? Find out, were they delayed in any of those? Social history, again, alcohol, tobacco, education. Here's your employment and travel. Support system at home. Why is that important? And we asked you guys all in your interviews, do you have a support system here in Orlando? Because you may need help. You guys are stressed out. Having a nice cooked meal once in a while feels good. If someone has a stroke and they come in and their left side is down, they have to go home. Is there anyone there to help them? If they live on the second floor, can they get up the stairs? So these are the questions you have to ask these people, because when you discharge them from the hospital, you have to make sure they have someplace to go and someone's going to take care of them when they get home. Family history, again, any psych issues, any neurological problems in your family, age and cause of death, and obviously any other neurological symptoms. Your ROS general, same things you ask normally, fevers, weight loss, sleep disturbances, and so forth. So these are all the same. Nothing really changes here. This is where we start getting into the neurological stuff that are specific to the complaint that they're here. Headache, any loss of consciousness, syncope or seizures. Okay, you guys have had cardio, so you learn about the cardio causes of syncope. So if someone passes out and falls on the ground, how do you know it's syncope from the heart, or is it a seizure from the brain? So those are the things to consider, because when anyone passes out, why do they pass out? What were their symptoms beforehand? Any speech issues and related functions, word finding, comprehension problems. Okay, comprehension issues, is that Broca's or Wernicke's? Wernicke's. Comprehension, so if I ask you a question, what is it cold outside? They'll say, I went on a boat somewhere. Broca's is a motor problem. Broca's is a frontal lobe issue. Why is it frontal lobe for Broca's? What's in the frontal lobe? I think someone said it. Precentral gyrus, right? That's in the frontal lobe. And what does that do? What function? Motor. So the act of speaking requires motor function. So my Broca's area allows me to speak. Wernicke's allows me to comprehend what you're asking me. Memory loss, is it recent or remote? Like some people can't remember the last 20 minutes, but from like 20 years ago, they'll remember everything. Attention and concentration and disorientation is another big one. They get lost. You all heard the story about the Alzheimer's dementia patients are wandering on the streets and whatnot. They get lost. They don't know where they are. That's why they have a lot of those memory centers that are like little streets, and they get used to all that, and they can stay there. They do well. Cranial nerves. You guys know how to check all these already. You guys did all the cranial nerve functions in the face. Any visual changes, facial numbness, deafness, dysphagia. Deafness, make sure you know, is it right or left or both sides? Okay, is it just unilateral hearing loss? Is it both? What test would you use for that? Weber and Renee. Okay, because they're having hearing problems. If they weren't having hearing problems, would you want to do a Weber or Renee on them? No, you don't. You don't need to do it. They're not complaining of any hearing problems. Limb, motor, and sensory. So any paresthesias. Radiculopathy. What's radiculopathy? But what is it causing what? Where? Okay, radiculopathy means it's referred pain. So it is a compression of a nerve. So like sciatic pain, the compression is L4, L5, but the pain is referred down that dermatome, down the leg. That is a radiculopathy. So yes, John was correct, but there's more to it. It means referred pain down the dermatome. That's why you have to know the dermatomes, because they're going to follow that pain, that route. Any paralysis, tremors, weakness, and obviously any involuntary movements, any spasms they can't control. Ask all those questions. Your cerebellar function, any problems with coordination? Do they stumble a lot? Can they turn corners easily? Do they get dizziness, vertigo? Any tremors? Tremors are a cerebellar function. So ask about those things. Psychiatric history, okay, also plays an important role in neuro. So we kind of overlap a little bit with behavioral health. We overlap with ortho. But again, with our program, a lot of stuff repeats. We do it all together, so it all works together. Obviously, all these are all different things you'll be talking to your patients about. These are big ones, too, that can deal with the frontal lobe. Remember, frontal lobe has those things. Like that can be issues with the frontal lobe and so forth. Must not miss symptoms. Thunderclap headache, worst headache of my life. Okay, not all the time, but the majority of the time, those type of complaints, subarachnoid hemorrhage. Sudden blindness is a major do not miss. Back pain is worse at night. That's usually going to be like an epidural tumor, that when you lay on your back at night, that tumor compresses the spinal cord and causes pain. Like the Princess and the Pea with the mattresses. Bladder or bowel incontinence. Okay, we talked about before the other day about S2 to S4, just an hour ago, whatever. Those are the sympathetic innervations to your bladder and your bowels. And if you lost that function, something's going on. Suicidal ideation with a plan. Okay, do not dismiss those things. Someone says, I want to hurt myself, and I bought a bottle of Tylenol and it's in my car right now. Like, don't let that person go home. Okay, moving on to our focused neurological exam. So, in this one, figure that out. So, the coma is the condition. The description means decreased loss of consciousness. And what's the structure involved? Meaning non-localized. So a coma can be any part of the brain that's causing a problem. Disorientation, lack of orientation to time and place. If a patient shows up to their appointment on time, the right location, the right building, the right time, they are oriented because they've made it to the appointment on time. Does that make sense? Anything with disorientation is going to be a temporal lobe problem. Amnesia, which is memory loss, temporal lobe as well. Aphasia, speech problems. This could be frontal or temporal parietal. Why can't it be both? What's in the temporal parietal region? Wernicke's. Okay, that's in the temporal parietal region. That's why comprehension could be a problem. Or is it speech, which is the frontal part? Inappropriate affect. Okay, inappropriate emotional display. This is usually due to bilateral cerebral damage. Agnosia, inability to recognize objects. Non-dominant parietal lobe. So that's where that dominance comes into play. If the patient is right-handed, they are left-sided dominant. So if someone comes in with agnosia, and I'm right-handed, so my left sphere is dominant, I have to look at the right side. This is my non-dominant hemisphere. Apraxia, inability to follow orders. That's your frontal lobe. So, levels of consciousness. Okay, you have to know these in order, and they're in severity going down. So either you're awake and alert. The next phase is lethargic or lethargy, where they just fall asleep easily, but you can still wake them up. They'll still get up. When you shake them, they'll wake up. Obtunded, confused, difficult to arouse. You really got to shake them. Hey, wake up, wake up, wake up. And eventually they'll wake up. Stuporous. Aroused with painful stimulation. What is an example of painful stimuli we can do to arouse people? Sternal rub is one of them. What's another one? Yep, take a pen and put it on their finger and pinch that nail bed. You can try it on yourself, it hurts. But they won't wake up with that. So those are some examples. And the last one is comatose. No response to painful stimuli at all. They're in a full-fledged coma. They are not responding to anything. So these are the different levels of consciousness. And we'll be discussing them a lot as we get to different parts of the sections. General exam, check your vital signs. Check for that facial rash of dermatomyositis, that heliocentric rash. Here are the eyes. Here's your nose. And it's that rash right there. Palpate skull for depressions, tenderness. Palpate the temporal artery. Why do you do that? Temporal artery, what are you worried about? What type of arteritis? Giant cell arteritis, so a temporal vessel artery. Check for carotid bruits. Why? What does that have to do with neuro? It's cardiac. Less blood to the brain. Remember, we have the major circulation of the brain is our carotids, and they start getting clogged up. They can cause TIAs. Percussive sinuses, that could be a reason for having headaches. Remember, you have your differentials. They have headache pain, facial pain. Tap the sinuses. It could just be sinusitis. And obviously, check your cardiovascular for rhythm and murmurs. What rhythm are you listening for more intently than others when it comes to neuro stuff with cardiac? AFib. Okay? Remember, AFib causes clots to form, and if one of those breaks free, it goes right to the brain. Middle cerebral artery and causes a stroke. Mental status exam. You guys will be doing this with your behavioral health simulations. So we're going to go through a little bit of it now. How's their appearance? How's their behavior? How are they talking? Are they just going off on tangents every other word? They start one thought and they go right to another thought and then another thought and they just keep going? Stuff like that. How's their mood, their response to your questions, the content of their thought? Sensorium is like awareness of the things around them. And your mini mental status exam. I don't know why these aren't showing up. Hang on. I'm showing up here. Is it showing up on yours? Okay. Why? Let me just open a PowerPoint. Maybe that changes it. This is my first time using GoodNotes. Here we are. Okay. So normal conversation. Start this up. Okay. Rapid speech, slow speech. Are they very slow in their words? Very quiet, rapid, and so forth. Mood, affective response. Is it normal? Emotionally labile, there's no affect. Depressed, angry. How is your patient? How do they appear to you? Content of thought, flight of ideas. That's like going all over the place. Hallucinations, even obsessions. They're obsessing over something. So check those things out as well. What's going on? Sensorium, again, this is around them. Orientation, person, place, and time. Your serial 7, spell world backwards. This is all testing your sensorium. Your recent and remote memory, cat ball tree. Fund of information, what is this? Present them with an object. What is this? Abstract thinking, interpretive proverb. We'll give one for that. And here's your copy A clock face. So here is the mini mental status exam. You will get this in your behavioral health sim. You don't need to memorize it. Some of the stuff you've already done. You've already asked that question. You've already asked, this question. 3 unrelated objects. You've already done that question. Count backwards by 7 by hundreds. You already asked that question. Okay, I told you 3 things. What are they? You've already done this part. Okay, now is where you have, this is the further part that you haven't done yet. Show the patient 2 simple objects, a wristwatch and a pencil, and ask them to name it. That's your fund of knowledge. Repeat the phrase, no ifs, ands, or buts. Okay, you want to see how their mouth makes those sounds. Okay, can they listen to directions even? If I ask you, okay, repeat after me, no ifs, ands, or buts, and they can't do it, they have a problem in some area, and you mark them off on these things. Next thing is an instruction. Take the paper in your right hand, fold it in half, and put it on the floor. So you say, okay, take this piece of paper, fold it in half, and put it on the floor, and see if they'll do that. Please read this and do what it says. And on that paper, you can even say, just close your eyes. If they open it up and they read it, it says close your eyes, and make sure the patient closes their eyes. Make up and write a sentence about anything. Obviously, must contain a noun and a verb, so have them write a sentence. Can they comprehend what they're writing? How is their writing? If it's very, very, very small writing, it could be other problems. Copy the picture. This is the two interlocking pentagons. Okay, so can they redraw this picture? So you add up all the scores, and the big number to remember is 24. If they are less than 24, and here are all the points right here, and you add it up. If they're less than 24, then basically you could say that they are not reliable as a patient because their mini mental status exam failed. They got less than 24. So you guys write on the top of your notes, unreliable, reliable. If they don't pass this, you can kind of say they're not really reliable. You have a question?
So the maximum scores are because there's multiple things to do in each of these sections, right?
Yeah.
There's five because there's 5 things they can say or answer.
1, 2, 3, 4. Yeah.
Okay. Because that's how you get partial credit.
Yes. I want to double check, make sure. Yes, there were 5. Okay. Speech. Can they talk? Aphasia, unable to produce speech. Dysphonia, difficulty in producing sounds or voice sounds. Dysarthria, difficulty in articulating individual sounds. So dysarthria, dysphonia, the different means. And again, no ifs, ands, or buts, and assess their comprehension. Follow directions. Oh, I got nothing. Let's go back. Okay. Always use open-ended questions. What brings you in today? What do you do for work? Because if you get someone with broker's aphasia, they can still probably get out yes or no. If you say, do you work? They'll say yes. You know what time it is? Yes. So you have to ask open-ended questions. They actually have to give you a verbal response with multiple words, not just one. Aphasia means without speech. It's a true language disturbance. Again, either impaired production or comprehension of spoken languages. So Wernicke's versus Broca's. The defect is going to be in these higher integrative processing centers. They may have some articulation problems. Aphasia also mainly after brain damage is when they mainly have these types of aphasias. Here's your Wernicke's aphasia. It's also known as a receptive aphasia. Can form words without difficulty, but the errors in the content. They don't make any sense in the content of what they're telling you. They are unaware of this. They don't know what's happening. In Broca's, they do know what's happening. It's very frustrating for Broca's patients because they're trying to get those words out, but they just physically can't. And again, lesion in temporal parietal lobe language area, that's where your Wernicke's is, temporal parietal. So again, here's an example. Ask a boat captain with left temporal lobe tumor to describe his work. He walked on it, always over, not making any sense. All you asked him was, how was life as a boat captain? Broca's aphasia is known as expressive aphasia. Unable to form or find words, and therefore they can't produce the words. They are aware of the deficit and anterior speech area. So you can see here this example. Describe a picture of a boy on a stool stealing a cookie, whatever going on. And then you'll say boy, girl, cookie, stool falling, water spilling, dishes. Still getting the content right, just not able to form all the words to make a complete sentence. So that's Broca's. Moving on to our cranial nerves. 5, 7, 9, 10, 11, 12. Brachiomotor group and the tongue. We'll see how those change. Cranial nerve, our special sensory group. You do your olfactory, taste, and auditory. We don't do taste sensations, but we do olfactory. You guys do the scents, different chapsticks or whatever. Have them scent, smell the stuff, and make sure they can recognize what the smells are. That means those are intact. Motor exam. You do your inspection for any atrophy or fasciculations. What are fasciculations? Twitches that go on. Talk about the tone of their muscles. If they have a lower motor neuron damage, they're not going to have any tone in their muscles. It's going to be flaccid paralysis. Okay? Grade on a 5-point scale. So motor exam, 5 out of 5 is full strength and doing well, and then it gets worse as you go down. Sensory exam, we do pinprick, sharp, dull, light touch, vibration, proprioception, 2-point discrimination. And all you're doing there is defining the sensory loss. What dermatomes, what nerve roots are damaged that's causing these types of pain and their symptoms that the patient's having. So remember, pain and temperature, your spinal thalamic. Position and vibratory sense are your posterior dorsal columns. Light touch says both, but for the purpose of this class, just so you know that it's just spinal thalamic. Yes?
So I would assume that both like proprioception, vibration, and also 2-point discrimination, all of them would be diminished equally between the damage there, or would only?
Yes, most of them will be damaged a little bit, but you still want to test all 3 just to make sure. Okay. And even the vibratory sense, where do you only do it? You do it on the thumb and the toes. Yeah. So if you can sense, these are the most distal positions we have. So if you can still sense it, that means everything upstream is still okay and intact because you can feel it at the most distal part, then everything above that is okay.
But then at that point, if they can't feel vibration, they probably can't also do proprioception?
Probably not.
Okay.
Compare symmetrically always, and always distal to proximal. Yes? Okay. Now, when you compare symmetrically, what side should you do first, the normal or the damaged side? Normal. Always do the normal side first. You want to have that as your baseline. That's where they are normally. And then you see how the damaged side is and compare it to the normal side and see how much of a decrease there is. So here's your sensory again, 2-point discrimination and your proprioception. Deep tendon reflexes on a 4-point scale. Remember for DTRs, 2 out of 4 is your normal. So you do your tendon reflex and it kicks normally, that's a normal response. If it's hyperactive and you get clonus happening, that's 4 out of 4 if they have clonus. And then obviously diminished response or absent reflexes is 0 out of 4. So if you remember for reflexes, 2 out of 4 is normal. Hyperreflexia, upper motor neuron disease. If they have hyperreflexia on DTRs. Hyperreflexia can also be caused, however, by hypocalcemia and some other metabolic disorders. So don't just assume, oh, they're hyperreflexic, it's just upper motor neuron disease. No, they could have problems with their calcium metabolism as well. When upper motor neuron lesions caused increased reflexes on one side, you should also find weakness on that same side. So if their right patellar reflex is hyperreflexive, they should also have some weakness on that right side as well. So here are the nerve roots you guys got to know. So C5 is your deltoid muscle, the reflex is your biceps tendon. So if I have a problem with my shoulder, I can't lift my arm up. It's very weak lifting my arm up. My deltoid is responsible for lifting my arm. If it's weak, I could have a C5 problem because that C5 is what innervates the deltoid muscle. Make sense? This is the same way it's going to be for all these next 10 slides. And I got to fix all this. Let's go back to this. That's not even working. Did it on here too? Okay. You guys can see it on your end though. So C6, wrist extension. The reflex is there. I can't see it on my end. C7, same thing. Just make sure you know what muscle in the reflex is used for each of these muscle groups. Here's C8, finger flexion. There really is no reflex for that. Upper extremity peripheral nerves. So again, peripheral nerve distribution. This should all be a repeat from PD and anatomy as far as the distribution of the nerves in the hand. Orange being the ulnar nerve is a big one, and median nerve are the purple one for like carpal tunnel disease, carpal tunnel syndrome. Other important landmarks, T4, T5 is the nipple line, and T10 is the umbilicus. We use those as landmarks. They're very easy to remember. L4, foot inversion, and your patellar tendon is L4. Okay, so L4 root is that one. L5, extensor digitorum longus, so it pulls your feet up. So if you're walking and you can't lift up your foot and you have foot drop, because you lost your digitorum longus innervation due to L5 damage, you have foot drop. When you're walking, your foot would just drop all the time because it can't plantar flex or dorsiflex. S1 is peroneus longus in your brevis, and S1 is your Achilles tendon. So S1 is your Achilles. And we have other reflexes. These are the ones, you can't see on, you can see on yours. But the big thing is, these are the ones that go to the brain and spinal cord. Let's see if anything is working again. Okay. I'll fix this stuff for next time. Okay, here's L4, foot inversion, patellar tendon. L5, digitorum longus. S1 is your Achilles and brain. Okay, so your abdominal reflex. I talked about this yesterday. This is a brain reflex. The upper abdomen is T8 and T9. So as you do the different quadrants in the upper abdomen, this is the nerve root that innervates that area. T11, T12 is your lower abdomen, below the umbilicus. The normal response is a skin stroke, is twitching of the umbilicus towards the quadrant stimulated. So if you go in the upper right quadrant, the umbilicus should twitch to that side. If it doesn't twitch to that side, either you're not doing it right on your exam, or they have a brain problem where the connection is not going from the umbilicus or the T9, T10 to the brain and back down. So spinal cord problems or upper motor neuron lesions are suspected. You'll see these abdominal reflexes be diminished. The cremasteric reflex. You guys will do this on the male standardized patients when you do that at the end of the semester. You will all do this. Everyone's going to do a female standardized patient and a male one. On the male one, we do what's called a cremasteric reflex. This is L1, L2. Stroke the inner thigh, and you should have ipsilateral rising of the testicle on that side. That's a brain reflex as well. Again, looking at upper motor neuron lesions, connection from that nerve root up to the brain and back down. Is that still working? Anal wink is another one. Looking at S2 to S4 damages. Remember we talked about bladder and bowel incontinence with damage to this S2 to S4 region. So if you prick the skin around the anus, causes a quick twitch-like constriction of the anal sphincter. Do this with people who have suspected sacral or cauda equini syndromes. So you do this anal wink and you make sure that the upper motor neurons are still working. Here's your Babinski or the plantar reflex. The normal response is for the great toe to flex when you stroke the plantar side. Great toe extension implies interruption of the upper motor neuron. Dorsiflexion of the big toe and fanning of the other toes is a positive Babinski's response. Okay, so any type of fanning, so forth, is a positive response. Clonus, you guys did clonus on your physical exam. It's a rapid upstroke of the foot, and you want to feel any tapping on your hand. That's what clonus is. I got quick stretch, maintain my slight pressure. Normal reaction is going to be one clonic jerk, one little beat in your hand. If you start feeling more than one bouncing, that means they do have clonus, and obviously upper motor neuron lesion problems with those patients. Pronator drift, okay, you guys do this. What's pronator drift? Have your hands out and just watch. Do they start dropping or whatever? Okay, again, upper motor neuron weakness if they have pronator drift. Supination is going to be weaker than pronation, the upper extremity, leading to pronation of the affected arm. Also very good for internal consistency, because if they fake the weakness, they'll always drop their arm without pronating it. People will fake things to get treatment or whatever. So like, oh, put your arms up, they just let it drop. They have to pronate the arm first, then it's going to fall. That's how you can tell if they're faking it or not. Pronation of one forearm, so just a contralateral lesion in the cortical spinal tract. A sideward or upward drift may suggest loss of position sense. Where are they in the world? If they don't know if they're up or down, that's a position sense problem, and so forth. So again, pronator drift, and you're checking to see what happens with their arms during that. Cerebellar testing, willful muscular contractions maintains posture. So your finger to nose, heel to shin, rapid alternating movements. That's all cerebellar function. If you can pronounce that, have fun with it, but that's the inability to perform rapidly alternating movements. Other cerebellar testing, gait, Romberg, and obviously looking for nystagmus, all that fun stuff. Your gait analysis, okay, how are they walking in tandem, on their heels, on their balls of their feet, tippy toes, how do they do that going back and forth? How's their arm swinging? They should have a normal arm movement when they walk. If their arms are like this when they walk, that's not good either. They want to have a natural swing of their arms as they're walking. So walking on the heels, that's how you test for dorsiflexion weakness. If they can't walk on their heels because they have foot drop, make sure you guys study and know what nerve root causes foot drop. Walking on toes is for plantar flexion weakness. How are they at plantar flexion? Can they get up on their heels and tippy toes? Any abnormality in the heel to toe walking, that tandem gait, obviously alcohol intoxication, we talked about that before, poor position sense, vertigo, leg tremors, and so forth. The cause of any gait abnormality must be excluded before you say they have a cerebellar lesion. You have to kind of figure out what's going on before you just say, oh, they have a brain problem. Most elderly people will have problems with tandem walking, not because of cerebellar function, just because they have general neuronal loss, problem with position sense, strength. If they don't have any muscle to support themselves when they walk, they're going to have problems with tandem walking. The unconscious patient, obviously you can't do a lot with a patient who's unconscious. Comatose can assume the nervous system is being affected at the brainstem or above, because that's the only reason why they'll be comatose. Anything happen in the spinal cord will not cause the patient to go into a coma, but any problems in the brain itself can. Goal: is their coma due to a structural problem in the brain, or is it just metabolic issues? Or it could be from both. So one of our lectures is going to be on dementia and delirium. And we'll talk about people in comas and what happens and so forth. We'll go more into detail. Causes of coma, it's a mnemonic called game times. And these are all the different reasons of causes for a coma. Glucose, okay, severely high or severely low glucose can cause comas. Anoxia, acidosis, medications, electrolytes, tumor, toxins, trauma, infections, metabolic issues like diabetes, that's above, epilepsy, and stroke. So in an unconscious patient, think, is this an intracranial problem? toxic, metabolic, anoxic, ischemic. In other words, do they have a head trauma, car accident, MVA, were they restricted or not? Do they hit the steering wheel? Do their head hit the windshield, whatever? Seizures, drug overdose is a big one, leads to comas. Any cardiac issues and other health problems. So, is it a structural lesion? Look at the left and the right side, are they the same? Any abnormal reflexes? So look at those other reflexes, anal wing, abdominal reflex, Babinski's. Are there any other issues going on with any other neurons? Mental status evaluation, and are they even responsive to any type of noxious stimuli? Do they wake up? So we talked about this already, how to do the different types of noxious stimuli. So the other really important thing to know about the unconscious patient is how is their body set up. There's two different posturing. One's called decorticate, and the other one is decerebrate posturing. Okay? The better prognosis is the decorticate posturing. So what is decorticate posturing? Adduction of the upper arms, flexion of the lower arms, wrists and fingers, and extended lower extremities. So the arms are like this. This is decorticate posturing. I have some pictures of the football players, and how they land. The other one is decerebrate posturing. This is the worst one. This one, adduction of the upper arms, but we have extension and pronation of the lower arms. This is decerebrate posturing, decorticate posturing. Okay, this is the player who got knocked out. Look at his arms. Decorticate posturing. Okay, I didn't have time to get a Tua hit, but he's got plenty of them on the internet. You can find him like this. Here is Trevor Lawrence. This just happened. Look at his arms. Look at the left arm. That's decerebrate. He's out like this. His other arm was kind of up a little bit. So not a good prognosis. I don't know what happened after that, but you can see how that arm is a lot stretched out. That is a decerebrate posturing from when he got hit. So again, here's just what they look like. We already went over it, so. Glasgow coma scale. The reason, you have to memorize the list. The number I want you to know is 8. 8 or less, you have to intubate. Remember that one. Okay, if they have a that means that they're not going to respond to you. If they're also in a coma, they can't take oral medications. They're not going to be able to swallow it. So everything's got to be done IV. You can't give these people oral meds. They're not going to do anything with it. It'll choke. So the biggest one I want you to know is just 8 or less. If their Glasgow coma scale is 8 or less, you can't give them any oral meds. You have to be careful about airway protections. They may need to be intubated because they can't control the processes by themselves. So big number for that is just remember 8. Last little bit is on your autonomic nervous system. Remember autonomic dysfunction, we talked a lot about with diabetics. They have issues with blood pressure, pupillary response. You'll see their pupils change. We'll go through that cranial nerve 3 palsies later on. Urinary output, GI function decreases because they have an autonomic dysfunction. So you get degeneration of those pre- and post-ganglionic nerves. First signs of pure autonomic failure is your postural hypotensions. They stand up, blood pressure can't normalize, it drops, they get lightheaded and dizzy, may pass out. Impotence. That's when men will start coming to the doctor when that stops working. Okay? But again, if they already have that problem, you know they have underlying issues that are going along with that as well. Any problems with urinating may lead to multiple system atrophy, and degeneration may be progressive. It also includes your lower motor neurons as well. And that's pretty much it. Okay? So on Friday, we'll do diagnostic testing, and we'll start one of the lectures.